Very good evening to one and all.
Good evening.
Yes,
Yes, sir.
sir. So today we have a talk as approach to vertigo in emergency room. This is going to be delivered by Dr. N. Balamurgan, who is my mentor, my guide. The main reason for asking sir to take here is I learned a lot of neurology with sir. I want to share the same feeling with you. So I requested sir to take two classes. So the first class is today. Sir is a senior consultant, neurologist. He's a outstanding student, both in his MBBS, a master degree, and as well as in a super specialist. He has completed his DM neurology from NIMANS and has got a lot of awards. With Sir's help only, I have done a lot of work. Without his help, nothing would have been happened. Sir is currently chairman for API Tamil Nadu chapter. Without any delay, I'm asking sir to start the session. So on to you, sir.
Thank you, Santal. Thank you for your generous words. And at the outset, I thank Association of Physicians of India, Indian College of Physicians, President of APA, Dr. Jyotir Moipal, Dean ICP Kamlesh Tiwari, and Dean-elect ICP Dr. Girish Mathur, and Honorary General Secretary Agamora, and the course director of Senthil Kumaran, and who is the key person, the brain behind this particular educative forum. And I straight away go to the topic, approach to giddiness in emergency department. A lot of books you might have seen on dizzy, vertigo imbalance, and sometimes it may be too much taxing taxonomies. And often they ask, can you define dizzy? Can you define vertigo, dizziness, giddiness? Dizzy is an imprecise symptom. It includes vertigo, giddiness, lightheadedness, faintness, imbalance. But vertigo is defined, it has a definition as an illusion of self and or environment. Again, I insist, don't use the word spinning. It is illusion of self and or environment. It may be spinning, swaying, bobbing, bouncing, tilting, or sliding. Whereas giddiness, lightheadedness, presyncope has a variable meaning depending upon the culture. Classically applied to presyncopal attacks, but lacks specificity and includes disequilibrium and imbalance. So, what's the message here? If in medical literature, when we say vertigo, it means it deals with vestibular apparatus and its connection from periphery to the center. It may be anywhere. And somebody says giddy or presyncope, it's most likely cardiac or partial hypotension related. But the practical issue is that patients don't know the medical definitions. Most often, they cannot distinguish these various symptoms, and the words they choose are often not reliable. So, you have to approach in a broader term as dizzy or giddy. When you are very specific vertigo, you are very clear about you are dealing with the vestibular apparatus and its connection problem. Again, when you specifically ask, they have asked and they found 62% of the selected persons, they selected more than one dizziness type on the multiple response questions. On the same question, nearly 50% didn't pick one or more types endorsed previously in open description. Of 218 patients not identifying vertigo, spinning, or motion on the first three questions, 70% confirmed spinning or motion on direct questions. Now we understand the difficulties from the patient's view about saying it's vertigo or non-vertiginous dizziness. So again, I repeat, the message is that don't give too much importance. If they give the specific information about spinning vertigo, then you can take it. Otherwise, it's all under broader category. You have to go with a proper approach. But as a neurologist, whenever a person says vertigo, during vertigo, we look at this eye movement because the speedometer of vestibular function is nystagmus. eye movement. So to start with, let it be giddy or dizzy or vertigo, the step one is it dangerous one? What are the dangerous? Arrhythmias, parasympathetic ischemic attacks, or sometimes a stroke. Then you, if you are clear it's not dangerous, then you go with step two, is it vestibular? If it is vestibular, is it periphery or center, what type? Then we'll go one by one. So the question one, the rotation of self or rotation of environment, no difference at all in terms of localization. Spinning, non-spinning, no. Vertigo, dizziness, no. Disease of semicircular canals usually present with spinning type of vertigo. That's one message, very clear. So let us see this spinning story of a patient recently we had on a Sunday. This patient came at 6 a.m. Actually, she got up at 6 a.m., went to make rangoli in her front yard. She bent forward and felt giddy. And specifically, a specific question was asked and said, no, doctor, it's a spinning sensation. And she sat down. No vomiting, no jets, no loss of consciousness. Within 3 minutes, she herself went back to her home without any assistance, called her spouse and narrated the event. So the spouse narrated that while she was narrating the event, she just passed out from the chair. So we all lifted her. Within a minute, she was normal. We gave her a cup of coffee and decided to consult a neurologist. So first attack of a spinning sensation when she bent forward. So then they reached our ER. While entering our ER from her car, at the gate, the ER gate, the patient was not conscious and had uploading of eyes and had a few jets, regained consciousness within a minute. So the duty doctor realized it could be something like a seizure, and they evaluated that. So they worked this case as a seizure, probably because of loss of consciousness, and all the investigations were done. So no clue. The blood investigations were normal, and this was the ECG and MRI, no infarct, no lesions. So the attending neurologist, on-call neurologist, I attended at 2 o'clock. That time the patient gave the history of spinning vertigo in the morning hours. And then I said, probably first attack would be a vertigo, positional vertigo. I examined the patient and then put the Dix-Salpic to provoke the attack. Probably the first attack was a benign partial positional vertigo. I was not clear about the second one. So there was no giddiness, there was no nystagmus. So Dix-Salpic was negative. So it could be a positional. Then the patient was advised to get admitted for observation because we thought the first attack was a vertigo, second could be a seizure with a syncope and at home, and the third at ER probably could be seizure and syncope. So, but they decided to take the patient out because he was very much conscious. You could see that when I was doing Dix-Salpic, he was very much well. So they decided to go out. When they moved out, again the patient suddenly lost her balance, fell down, and was having grunting respiration with uploading of eyeballs and passed urine in motion. She regained consciousness within 2 to 3 minutes, no tongue bite. So video recorded by one of the bystander says that this was the picture. So far what we thought is that vertigo, some form of vertigo, probably with syncope or seizure. So when you see this catastrophic event, we are very clear something is happening. So you could see a gasp and people were shifting from the outer veranda to again inside. So that time saturation dropped to 80 and a vertigo turned out to be a catastrophic vertigo or a syncope. So we thought it could be a pulmonary embolism because of saturation drop or acute coronary event, and you could see the ECG. So Q3, T3, some changes are there, but no tachycardia. Obvious no tachycardia here at this point, and immediate echo showed you could see the right ventricle strain. So the right ventricle is dilated. So whereas the left is okay here, the right ventricle is ballooned. So acute RV strain. So we didn't have any time to ship the patient for CT angio. So we proceeded with the nectar place, and within 5 minutes, the RV started functioning and recovered. So the next day, you can see here. So almost the RV size has come to near normal. So we could plan for an angio. Angio showed a submassive pulmonary embolism in the both. Probably after thrombolysis, we did that. So patient had a massive pulmonary embolism presenting as a vertigo, then syncope. So the message is very clear. So just you can see how the patient had the attack and entering the ER. So this is a CCTV, what we captured. So the patient is now the patient is yeah. So collapsed. That's all. They were literally shifting the patient to the bed. So when they decided to go out, you can see here. So this is the patient, the blue saree. She's very much stable with all her parameters. She is moving out, saying that we are normal, we want to go out. So you could see now here, holding rest collapsed. So the message is very clear. Any acute vertigo, dizziness, giddiness, the dangerous things like arrhythmias, TIAs, strokes, pulmonary embolism has to be ruled out. Then is it vestibular? When you say vestibular, it can be peripheral or central and its connections. The peripheral vestibular apparatus. Up to this point, people call this a periphery. That means vestibular apparatus, vestibular nerve till its nucleus. From the nuclei, its connection to the oculomotor nerve, its connection to the cerebellum, its connection to the vestibular spinal tract, and its connection to the brain through the thalamus or central. So the question comes, is it a peripheral vertigo or central vertigo? How to differentiate? Before that, again I insist, vertigo is a symptom complex. The patient can have vertigo alone because it has a connection with almost 4 major systems. They can have a vertigo, which is a perceptual, what you have an illusion. It could, because it has a connection with the oculomotor, they can have oscillopsia, or you can see the nystagmus, and it has connection to the vestibulospinal tract. So ataxia, fall, near fall, and reticular formation and atomic system connections may cause nausea, vomiting, palpitation, and sweating. So it's a symptom complex because of the central connections. So depending upon it's the company they keep and the company in stable, you can localize which part they are doing it. So number one, depending eighth now, hearing loss, tinnitus, this could be the ENT problems, maybe they may be going nystagmus, oscillopsia, brainstem connections, diplopia, dysarthria, ataxia. They most often go to the neurologist. So fall, near fall, if they have fractured, they may go to the orthopedicians. But when they have long tack signs, that may be neurology, and nausea, vomiting, palpitation, sweating, the limbic connections it has. So dysautonomia and cardiac, neurological or psychiatric presentation may be there. So the vertigo is not a single symptom, it's a symptom complex. So how do you approach? Now, the best approach is not the description of the symptom alone, like dizzy, giddy, vertigo. Forget about that. Or comes under one. But you have to look at the combination of other symptoms, oculovestibular or vestibulocerebellum, and its autonomic symptom. But once you say it's probably a vestibular connection problem, the approach is very simple. We call it a titrate approach. Start with timing, triggers, associated symptoms, targeted examination. That's all. Timing, if it is less than a minute, in seconds, most often it is vestibular paroxysmal. Less than in seconds, like trigeminal neuralgia, people can have short vestibular paroxysmias because of the compression of the vestibulocochlear nerve by an aberrant vessel. It exactly mimics like the trigeminal neuralgia, where there is a pain here. This is very short lasting in seconds of vertigo. And they may have tinnitus. The tinnitus, they say, is a typewriter type of tinnitus, in contrast to the pulsatile tinnitus where you get in a vascular or non-pulsatile in other conditions. And less than a minute, mostly vestibular paroxysmia, cardiac arrhythmia, benign paraxysmal partial vertigo, and in minutes, less than 20 minutes, but more than a minute is most often BPV or TIA. In 20 minutes to hours, often it's migraine vestibular, it could be TIA and Meniere's, and hours to days, two important things, vestibular neuritis or an acute stroke. The one disease that can go to most of the areas is vestibular migraine. It can be in minutes, it can be in hours, it can be in days. And next, look at the triggers. When the patient says that lying down, getting up, probably benign paroxysmal partial vertigo. Getting up could be benign paroxysmal vertigo. Getting up could be orthostatic hypotension. Getting up could be gait disorder. Turning the head to right or left, probably benign paroxysmal partial vertigo. But the turning the head right or left in bed or in erect posture also, in sitting posture also, it could be a rotatory vertebral artery syndrome. Look at that. So, exercising with the left hand produces vertigo, subclavian seal syndrome. Shaving the neck area, touching the chest with the chin, carotid sinus hypersensitivity. Most often syncope is common there, but they describe the feeling of the pre-syncope as a vertigo. On travel, motion sickness, vestibular migraine. Triggers of migraine like smell, photic stimuli, spicy food, sound, sleep deprivation. Most likely vestibular migraine. As long as maintaining a position, no vertigo, but any change in the position triggers an attack, most likely vestibular migraine. These are the patients, they keep their head in one particular position, they never allow for minutes together. The A in the titrate is associated symptoms. So we classify this into 3 to 4 syndromic compounds. Acute vestibular syndrome or acute prolonged vertigo. Episodic vestibular syndrome, chronic vestibular syndrome. As the topic is mainly for emergency physicians, I focus on acute vestibular syndrome and episodic vestibular syndromes. Acute vestibular syndrome on chronic, they may present to ER as an acute. So acute vestibular syndrome is acute onset or continuous vertigo lasting longer than 24 hours by definition. But when they come to emergency, more than an hour, we have to practically call this is acute vestibular syndrome. That's the reason they have said that acute prolonged vertigo. They may have head motion intolerance in any direction and unstable balance associated with nausea, and it may be acute or subacute. If it is acute, two important things, vestibular neuritis with a stroke. Subacute could be Wernicke's encephalopathy or demyelination, dehydration, anemia, or drug-induced. Episodic vertigo may present as acute or first attack to ER, but when there is episodic spells, 2 or 3 spells has happened, lasting for seconds to hours, it can be spontaneous or it can be triggered. Spontaneous in seconds is vestibular paroxysmia. Spontaneous lasting for minutes to hours is vestibular migraine or Meniere's. Triggered, the most classical example is benign paroxysmal partial vertigo. So, if your classification is acute vestibular syndrome, otherwise ongoing vertigo, it is not paroxysmal, you have to approach with hints: head impulse, nystagmus, test of skew, what we call as hints. If it is episodic vestibular syndrome, you have to go with positional test, Dick-Salpic or supine roll test to say which canal is involved. That's all. The message is very clear here. And what the emergency physician should know in vertigo evaluation is emergency clinician should receive training in bedside physical examination techniques for patients with acute vestibular syndrome, HIMSS, and Dick-Salpic. My focus over the next 30 minutes on these two things. So any patient coming to ED with vertigo, acute vestibular syndrome, ongoing vestibular vertigo with nystagmus, brand them as acute vestibular syndrome. So acute vestibular syndrome, two important things. One, it could be ongoing stroke or it could be vestibular neuritis. So the nystagmus is the clue here. So this was first defined by Horson and Ballo in 1998. Acute severe ongoing vertigo, nausea, vomiting, partial instability, and spontaneous nystagmus. The nystagmus is not triggered. It is not position related. It is spontaneous nystagmus. When you see in ER acute vestibular syndrome, look for central signs. If the patient has facial weakness, motor limb weakness, or sensory loss, the danger is D, like what we call as a brainstem Ds. Diplopia, dysarthria, dysphonia, dysphagia, dysmetria, or severe ataxia, unable to walk unaided. Mild ataxia can happen in vestibular neuritis, but unable to walk or stand without help is severe ataxia. New onset headache or neck pain. You need not to go with hints, you can straight away go for evaluation of stroke. These signs are less sensitive but highly specific. When a person comes with vertigo with any of the central signs, it is stroke. That's all for all practical purpose. You have to evaluate for stroke because you have to go for a thrombolysis within 4.5 hours. So that's the reason emergency physicians are advised to learn differentiating acute vestibular syndrome. The two important things, acute vestibular neuritis versus a stroke. If you don't understand obvious things like weakness, sensory loss, or other neurological signs, the subtle things won't matter much. So can a stroke present with only vertigo? Yeah, that's the issue here. So when they have obvious lateral medullary syndrome features like a palatal palsy and ataxia and having a facial weakness, then it's very obvious. You won't think about vestibular neuritis, isn't it? So when a patient comes to ER only with vertigo, no other central signs, the question comes is it a stroke presenting as a vertigo? Whether I should go for an MRI or CT, thrombolysis, or is it vestibular neuritis? So from 18th century, a lot of tests has been done to differentiate these things, but you see that 2009 onwards, this hints picked up. Because from 1996 onwards, we started doing thrombolysis. Nearly after 10 years, people had medical legal issues of delayed diagnosis of stroke in ER, so no thrombolysis, especially basilar strokes. So if you miss that, if you miss the thrombolysis, you are missing a patient and medical legal issues are there. So we need some guidelines at ER because MRI may be normal in the initial phase. Obviously, CT will be normal. So for vestibular neuritis and also basilar stroke in the early phase, even they have only vertigo. So from 2009 onwards, the hints become popular, and then the added hints was not that much. It is not giving more than 96%. They added the hearing loss, then added the ataxia grade 2. So we'll see what is hints: head impulse test, nystagmus, test of skew deviation. The head impulse test is normal. It's mostly central. That means for all practical purpose, central, acute central is stroke. A tumor in the pons can also produce hint central type, but we are dealing with acute vestibular syndrome. So a normal head impulse test is for central. Nystagmus, which is direction changing, gaze evoked nystagmus. On looking to the right beating, looking to the left beating, it's a gaze evoked nystagmus. Pure vertical, pure torsional, non-fatigue. So it's more in favor of a central. Horizontal and torsional is more in favor of periphery, whereas vertical and torsional is more in favor of central. But pure vertical, pure torsional is more in favor of central rather than the combinations. Test of skew, abnormal vertical ocular alignment. So any one in the upper row is positive, we have to go for central. To say periphery, head impulse test has to be positive or it should show a corrective circuits with the head turned towards the side of lesion. So rather than saying positive, negative, we can say head impulse is normal, head impulse is abnormal. The abnormal is corrective circuits. When there is a corrective circuit, it means there is a lesion in the periphery, the center is coming and then doing the corrective circuit. So nystagmus is unidirectional, horizontal and torsional for classical periphery and worsens with the removal of the fixation and no test of skew. If any one is positive in the central, that means normal head impulse, direction changing nystagmus or test of skew positive, any one is positive, we have to consider this as central. To say periphery, all three has to be positive. And with this 96% sensitive and 98% specific compared to 14% false negative MR in the first 48 hours, people relied on this particular hints. But we wanted to more, so we added hearing loss. When there is acute hearing loss, it is central. That's a teaching. But in practice, I don't agree for that. Because when there is a vestibular neuritis, when it spills over and produces a labyrinthitis, that also can produce hearing loss. Central strokes will not cause hearing loss because once it enters the brainstem, it is a bilateral representation. If at all it is what they mean central is a stroke, stroke involving the labyrinthine artery can produce acute hearing loss. So I don't give much importance to the hearing, but I give much importance to the ataxia. There is no ataxia or grade 1. That means no ataxia is otherwise called grade 1. It's most likely peripheral. When the person needs support to stand, to walk, it's grade 2. When the person, even with support, they are not able to stand or walk, it's grade 3. When the person is having grade 3 ataxia, put it as a central. Grade 2 is in between. Grade 1 is for periphery. So when you look into this, add this goes to the perfect 100% sensitive when you add this ataxia. So because ataxia can happen in vestibular neuritis, but the vestibular neuritis ataxia patients, most of the time, they won't be having ataxia or they have ataxia with mild, with help they can walk. If it's a grade 3, err on the stroke side. Now I will be showing some cases. So here, how head impulse is being performed. Ask a patient to look at your eyes or your bridge of the nose and make a sharp, sudden jerk of 15 degrees to the right or left. That's called head impulse. Head impulse test is not equal to your dorsal movement. That is slow. See here. On turning to the right, you can see the catch-up circuits. Towards left. Towards left. Left, no issues. It's normal. Now, right, you can see the catch-up circuits. On turning to the right, you can see the catch-up circuits. It will be consistent. I don't go for fatigue. So on turning to the right, there is a catch-up circuit. So it means the person is having right vestibular problem, periphery. So it's a very classical. This patient had, in addition, you could see here this person is having left beating horizontal nystagmus. You can see here left beating horizontal nystagmus. I'm sorry, this is not coming nicely. Okay, fine. So this obvious left beating horizontal nystagmus. So you can see here left beating horizontal nystagmus. It's a grade 2. On looking at the right, no nystagmus. On looking to the left, there's a left beating nystagmus. So this is very clear. This patient is having able to walk without support. So if at all we can put as a grade 1, fine. So this patient has a corrective saccades with the head turned towards side and unidirectional horizontal torsional nystagmus, no skew deviation and no ataxia. So this is for periphery. So this is a vestibular neuritis. So again, you can see here, this is another patient. I'm going to check the head impulse, turn to the right, no catch-up saccades, turn to the left, no catch-up saccades, right, no catch-up, left, no catch-up. So head impulse, grade 3 horizontal nystagmus. The nystagmus is beating towards right. The head impulse is for central. We are saying that this patient I'm showing the head impulse for central, but this is unidirectional nystagmus, horizontal. So it's not bidirectional direction changing. You may think that this is for periphery, but you have to put all those things and then find. So this is a right beating, unidirectional nystagmus, and you can see that the eye up and down here, there is a tilt, skew deviation was positive. You can see the same patient, what I showed here. The right beating nystagmus even and looking straight. So this patient had so ataxia grade 2. So this patient had some features of peripheral, some features of central. So I told you any one feature of central, we have to look for central, you have to evaluate as a central, that is stroke. So here, this patient had a unidirectional horizontal nystagmus, but this patient had head impulse normal and test of skew and ataxia grade 2. But you can give importance to these two things. Any one positive in the central row, it means it is central. So this patient had an infarct strategically located in the medulla, not producing 9th and 10th. If the person has a 9th and 10th cranial knob, you will not go for hints at all. It's very obvious it's a stroke, isn't it? When they have only vertigo, when they have a strategically located infarct in the lateralmost part of the medulla, or if they have in the vermiform part of the cerebellum, or when they have classically located in the vestibular nuclear component, they can have vertigo alone as a presentation of stroke. So now we have seen two cases. One, hints suggestive of periphery, vestibular neuritis. Second, hints suggestive of central, turned out to be stroke. So in ER, any ongoing vertigo, that means continuous vertigo, it's not episodic vertigo. So let it be 1 hour or 2 hours or 3 hours or 24 hours. If it is acute, only two possibilities for all practical purpose: stroke versus vestibular neuritis. Go with hints, head impulses, learn head impulses. If head impulses shows a seconds, corrective seconds, you are dealing with periphery, and nystagmus character, test of skew, and ataxia helps you. Suppose it's episodic vertigo. Is it? That means episodic spells lasting for seconds to hours. It may be spontaneous or it may be triggered. Triggered means changing the position, bending forward, getting up, lying down, turning right or left. So these are all causes, but these are the rare one. We will look at the BPV now. So triggered episodic vestibular syndrome. So we have to go with positional test. All positional vertigos are not benign paroxysmal vertigo. Number one. All vertigos increase in severity on head movement, even vestibular neuritis also. Even vertigo, migraine, vertiginous migraine. If vertigo continues as long as the position is maintained, It's very unlikely benign fractional vertigo. It's a most important point. When you put a person in a particular position, the otolith moves and it settles. When the otolith moves, that produces vertigo. It has to settle within a minute, mostly within 30 to 40 seconds. During that time, they have vertigo, and you can see the nystagmus. That's the reason I call the speedometer is your eye. Once it settles, the vertigo has to settle. Once the otolith settles in the most dependent, that's the reason vertigo won't continue. The positional change triggers a vertigo, and in benign fractional vertigo, it's spontaneously it gets resolved within few seconds, maximum about 40 seconds in most of the benign fractional vertigo. Does a particular position trigger the attack? Yes. It should settle within 60 seconds, even in that triggering position. If no head movement means no movement of the semicircular canal. No movement of the semicircular canal, so no movement of the otolith. So no vertigo. This concept you have to be very clear. And always examine the eye position, primary position, before putting the patients in the positional test like a big salpic or superindoral test. If nystagmus are seen in primary position itself, unlikely positional vertigo. I said nystagmus is present only when the particles are in motion. The particles, what he calls the autoconia, made up of calcium carbonate particles. We all have calcium carbonate particles sitting in the atrial. It's attached in the atrial cells. When it gets detached because sometimes degeneration, injury, it has to move, or it may move to the most dependent semicircular canal. So when you see a person having nystagmus in primary position, if it is a gaze-evoked nystagmus, that means on looking to the right gaze, right horizontal nystagmus, looking to the left beating nystagmus, or looking up beating, looking down beating, gaze-evoked nystagmus, direction changing gaze-evoked nystagmus. That means looking to the right beating, look at the left beating. Spontaneous downbeat nystagmus, pathologically impaired smooth pursuit. Always examine second and smooth pursuit when they have gaze-evoked nystagmus. If anything is positive, that is central, cerebellum. So just a recap, this is atrial. From the atrial, when the autoconia gets dislodged, it goes to the semicircular canal. This is a hair cells. Once it goes to the semicircular canal, it cannot come through this way because hair cells forms a membrane here. So it has to come back again. So that's the reason we do a physical maneuver to bring it back to the atrial. So this was the semicircular canal. Posterior is the most common among the benign fractional vertigo. Nearly about 60 to 70% is a posterior canal, and nearly 10 to 20% is horizontal canal. Anterior is very rare. I'll show some of the posterior canals. So if you suspect posterior canal, when you suspect posterior canal, when a patient says, these are vertical canals, posterior canals and anterior canals are vertical canals. When a patient says vertigo, dizzy feel, or spinning sensation, when the patient is lying down or getting up, it's a posterior canal. So we have to go for Dick-Salpic. So this is a way of doing Dick-Salpic. Turn the patient's head towards you for 45-degree and put down the patients from the sitting to the supine and head down. So observe the eye movement here. Because when you turn this way, the posterior canal comes straight, or what you call as a perpendicular, so that the particle here will move. So when there is a movement of the particle, that produces vertigo. Because when it is moving out, the hair cells get excited. That produces vertigo. So you could see here this patient. I just turned 45-degree and then putting him into 135-degree down. So 90, then again 45-degree down. What you saw is the nystagmus for See here. What you saw is a beat and right dorsal nystagmus. That's all settles. It lasts for about few seconds. So this is a classical way of Dexalpic. Always wait, don't do it fast and then say that there is no nystagmus. So you do it. So waiting, no nystagmus, right Dexalpic. So I was waiting for I always wait for nearly about at least 30 seconds before concluding it's negative. Because sometimes the particles takes time to move. So there is no nystagmus at all. This is one of the reasons benign paraxial partial vertigo, Dexalpic negative sir. I suspect is strongly posterior, but it is negative. Now you see here. Carefully see that? Yes. Sure. It started nearly about 28 seconds later. A beat and right dorsal. So it is right posterior canal BPV. So again, one more patient. I think the same patient which I showed earlier, and how we treat them. Yeah. So a beat right dorsal. So it's a right posterior canal on Dexalpic. So once we confirm it is a right posterior canal, I prefer there are two ways. One is Eppes, another is Siemens. I will show both the methods. The right posterior. I was doing Siemens liberatory maneuver. This is called Siemens or extended Siemens. So the right posterior canal, the right head, the right parieto-occipital region has to be down, touching the cot, or it has to be down. Then very fast movement. So the left frontal region has to be down. By this maneuver, I am taking out or pulling out the outer from the semicircular ampullary end to the non-ampullary end to the utricle. So this patient has to lie down in this position. Very simple. Siemens is very simple, but this patient has to move very fast. So here, again I say it is a right posterior semicircular canal. A right parieto-occipital region has to be down. This position stimulates because this moves the otolith. They will have nystagmus slightly. Then immediately, very fast, you ask the patient to go in that direction. Their fronto-orbital region has to be down. So, this I'm showing how I teach is that. So he has to be down here. So we educate the patient. This is a way that occipital and orbitofrontal. So the right posterior canal, right parieto-occipital has to be down, and after about 30 seconds or 1 minute, so this is a down. Then, because this is a one disease, you can suspect, you can prove Dexalpic, and you can treat in your OPD itself. I don't know any other disease where a physician can diagnose, suspect, diagnose, confirm diagnosis by that's what a DD. On Dexalpic, you get upbeat right dorsal, it has to be right posterior canal. There is no differential diagnosis. And you can put the patient in Siemens liberatory maneuver, and 2-3 times they will be normal. You can teach them, and then I give the video what I record to them, and they can go home and then they do it for 2-3 days. So this is how we record in our lab. So here this you can see this patient. Sometimes the nystagmus is best elicited in dark when the fixation is removed. Now you can see that here pupil is dilated. It is by the machine. You can see that right dicksalpic, upbeat, right torsional. When we strongly suspect benign proximal vertigo, but we are not able to get in the day in the light in the room, so we shift the patient to the lab, because in the lab with the closed eyes we could monitor, because the laser beam measures all those things and gives the idea about this. This is again I show here. This is on right dicksalpic after about 2 to 3 seconds. Now you can see here a beat right torsion lasts for about 8 to 10 seconds. Very classic of dicksalpic producing a beat right torsional. There is no different diagnosis. It has to be a right posterior. So some people they can't get a fast and then turn. So we can go for this. At least we need a broader bed, and they have to go from turning from one side to other side. Obese people really tough, and I am comfortable with Siemens than the Eplis. So if some people go with this, so this is the right posterior canal, and you could see a transient a beat right torsion. In Eplis, the first phase is dicksalpic. So it will show a beat right torsional, what you're seeing that. Then from there, 90-degree towards left, and then again 45-degree looking down. So this is Eplis maneuver. We need a broader bit. So you can see here, from there, I have seen the moving, the right posterior canal. Torsional is not beating. Right posterior canal beating. Now I'm going to do from this, I'm converting to this from here. So I'm turning to from there 95-degree. And then again I had to go for 95-degree. Sorry, 90. From initial 90, then I had to go for nose down. So again 90-degree. From that position, you can see here, we have turned to down here. So from here, down, the nose down, what is called the nose down. So now you understand the difficulties of Eplis, especially obese people. So I could see when I put this position, the particles going down, that means the nystagmus goes in the reverse direction. So this is a way that it has been done. Some of the patients may have, instead of having a posterior canal, they may have a lateral canal. So lateral canal, if you learn posterior canal, you have learned nearly about 60 to 70% of the BPV. The next one you have to learn is looking at the horizontal canal. We do supine roll test. We ask the patient to lie down and turn the right and left. When to suspect this, the patient says, when I turn my head to the right, I have nystagmus. When I turn my head to the left, I have nystagmus. This is most likely horizontal canal BPV. There is no nystagmus at this point. In sitting, no nystagmus. Always do primary position, the spontaneous nystagmus. If it is there, it could be central. So no nystagmus in sitting or in lying down. Now I'm asking the patient to turn a right lateral. Right side so you can see here now, obvious crescendo, decrescendo, this type of nystagmus, it's a beating towards right. On turning to the right, this beating towards right. On not on looking towards the right, I have turned the head right, that produces a right beating, what we call as a geotropic, because it's beating towards the earth. So they named this as a geotropic. settles. That's all. Maximum 30 to 40 seconds. Because by 30 seconds, the autoconia goes to the most dependent position part of the semicircular canal. So there is, after that, there won't be any movement. So the nystagmus has to settle. On right lateral, then I am turning the patient slowly to left lateral. See here. So it's central, turning from the right to the center. This center produces left beating. He is in center because I moved the particle. Even in center, there is a nystagmus now. Left beating. This also gives me clue that there is a right horizontal canal between. Now, I'm turning to left. So, on turning the head to the left, he's having a left beating nystagmus. So, this is called geotropic nystagmus. It's more on right side, and even in neutral, this is beating towards the left. It says that the right horizontal BPVV. So, this is best managed by Guffoni method. Or we ask the patient, in as far as the horizontal canal is concerned, if you see that it's a right horizontal canal, you ask the patient overnight sleep on the left lateral. That's called forced lateralization. So now I am asking the patient to turn the left. You could see a left beating nystagmus now. So this is very classic. It's not be confused with the gaze stroke nystagmus or cerebellum. Here also on right beating, on left beating, but not on looking right. On turning the head to the right beating, on turning the head to the left beating in supine roll test, it's called direction changing positional nystagmus. Not direction changing nystagmus. Direction changing positional nystagmus. It's indicative of lateral canal. Here, the beat is more on the right side, so right horizontal canal. Ask a patient to sleep on the left side for 12 hours. That's all. That's very easy. Or you can go for Buffoni for its correction. So, ladies and gentlemen, acute vestibular syndrome, you have to go with HIMSS. Episodic vertigo, if it is triggered by position, go with positional testing Dixalpic. If it is the posterior canal, go with Eplis or Siemens. Or if you suspect horizontal canal, do supine roll test, go for forced lateralization or Buffoni. If it is spontaneous episodes, it happens for few minutes to hours and subsides. It's not triggered. Most of the time it happens in their home. By the time they come to you, they will be absolutely normal, like epilepsy. They said that I had a severe vertigo. Whatever position you do, you won't get it because it's not triggered by position. In this group, the most important two things are vestibular migraine and Meniere's. In practice, I see most of the time vestibular migraine is misdiagnosed as Meniere's. Please take this message. Vestibular migraine is 10 times more common than Meniere's. So here is a patient, IT professional, works online for 8 to 10 hours per day, chronic episodic headache, and in addition having vestibulocochlear symptoms. What is a chronic episodic headache? This patient had unilateral, pulsatile, moderate to severe in intensity, aggravated by physical work, associated with nausea, vomiting. This is called migraine phenotype. He is having chronic episodic headache, probably migraine. We call this PUMA, unilateral, pulsatile, moderate to severe intensity, aggravated physical work. This is called migraine phenotype. Whereas bilateral, non-pulsatile, mild severity, we call as tension phenotype, tension type phenotype. So, in addition, if the patient has vertigo, tinnitus, hard of hearing, remember hard of hearing, aggravated physical work, associated with nausea, vomiting, when the spontaneous vertigo here. So, when a person has migraine-like and BPV-like, Meniere's-like, most likely it's a vestibular migraine. This is the most common vestibular complaint in my vertigo clinic. Often underdiagnosed, This is one of the most common cause of episodic vertigo. Even with a headache, my primary diagnosis will be vestibular migraine when the vertigo is not triggered, that is not positional. So I teach all episodic vertigo. When you are not able to document any vertigo, any nystagmus by any positional maneuver, it's most likely you are dealing with vestibular migraine. Typically, travel sickness in the early childhood, most of the time we miss the history. When they come with vertigo, episodic vertigo, not triggered, ask only one questions. During your childhood, what about your travel? You enjoy that? Immediately they say that, oh, no, I had vomiting. Or even now, if I travel long, they have. That's a very classic thing. Migraine with without aura in the 20s and 30s, and episodic vertigo in 30s and 40s. This is a timeline. Okay. And most often they will give a family history of migraine. But you have to ask family history of headache, not migraine, because most of the time in India, migraine is misdiagnosed as sinusitis. One vertigo with variable duration, it may be minutes to hours to days, is vestibular migraine. Motion sensitivity and sensitive visual motion. So motion sensitivity on travel, they have this vertiginous feeling. Sensitive visual motion means in the movie hall or in the malls, because of the movements of a lot of people, this get triggered. But on travel and moving, when you are focusing on, this is very classic when people travel and they text. When the people travel and see the video, that's the most dangerous. So I see more vestibular migraine because of this cell phone texting while traveling, not driving. And I know that you won't be doing that. But when you're sitting in the next to the drivers and then you are seeing a video and the vehicle is moving on, so that is motion sensitivity and sensitivity to visual motion. So both the things combines and it stimulates the vestibular apparatus, and there's one strong stimulus that triggers the vestibular migraine. Ask a patient to take selfie video at home during the attack, because these are spontaneous attack. It is not triggered when they come to your home clinic. They may not be having this patient. I think another 3 minutes I have. I'll be finishing. அப்பயே தலைவலி வந்ததா அல்லது அதுக்கு முன்னாடி தலைவலி லைட்டா? அதுக்கு முன்னே கொஞ்சம் வந்ததுங்க. அந்த தலைவலி எவ்வளவு நேரம்? So he was not having anything, but I asked a patient to have at home. She asked his daughter to record the event. See what a classical left beating nystagmus. He said that it lasted for about, I could see the whole video. It lasted for about 2 minutes. So once he gets that vertigo, he went to the bed and asked the daughter, you record my eye movement. Doctor asked me to record my eye movement. What else you need for a diagnosis? So this patient had headache from morning and had a vertiginous feeling. Immediately he was lying down and asking the daughters to record. So then it lasted for about 2 minutes and settled. So it may last from minutes to hours. So very classical vestibular migraine. So ladies and gentlemen, the approach to giddy, dizzy or vertigo is not symptom based. Don't give much importance, whatever things that put in the common group. So is it dangerous like pulmonary embolism, arrhythmia, or is it vestibular? If it is vestibular, is it a central? The question is it a central or periphery? And go with the titrate approach with the timing and triggers, associated symptoms and targeted examination. Only 3 syndromes are there: acute vestibular syndrome, episodic vertigo. In episodic vertigo, it may be spontaneous. The classical example is vestibular migraine and Meniere's, and the other one is positional vertigo. And this is the time, durations, and these are the 3 different things. Again, I repeat, acute vestibular syndrome, go for hints, and positional vertigo, go for triggered vertigo, go for positional test. I thank my team for recording most of my patients during the attacks and helping me in documenting those cases. Thank you all. So this, I said, the speedometer is, I see a child having the eye movement, very classic physiological nystagmus. Thank you all.
Thank you very much, sir. As usual, it was a very wonderful and informative, sir. So there are a few questions in the chat box.
Sure. Yes, sir.
So one person asked, spicy food as a etiology of migraine, first time noticed.
So yeah, any stimulus, you have 5 senses. Any senses if you stimulate abnormally or hypersensitivity, that may be a smell, or that may be hearing, that may be spicy food, or that may be emotional, or that may be body contacts, that even the sexual activity can trigger the migraine.
So the second question is, how many days patient have to do this Semont maneuver?
Generally, we say 3 times in a day. I advise to do the exercise before going having food, because after having food, if they have nausea, vomiting, they may vomit and aspiration may be there. So 3 times, every time they have to do 3 times, and 3 times in a day for 3 days. Ask them to come for review at the end of 3 days. Most of the time it settles.
Sir, what about the recurrence after this maneuver?
Nearly 30% of the patients do have recurrence over the next 2 years, because the pathology, you have to understand, the autoconial particles, the calcium carbonate particles, we all have, gets disintegrated at the age of 50, 60. So the same age keeps on going. So more disintegration may be there. So when it gets disintegrated, that's a very small, minute, like a sand particle, and it enters in any of the canal that triggers it. So there are some studies which have said that giving vitamin D3, giving magnesium prevents further events, but there is no strong evidence for that. Head injury
Sir,
also can precipitate this dislodgement of these particles. When a patient coming after head injury, 2 to 3 days later, having severe vertigo, don't say it is a concussion-related vertigo. So it's probably the head injury has moved the particle out. It has gone into one of the canal.
sir, which positional maneuver are diagnostic and which one are for the treatment?
So I showed you, when you are suspecting the vertical canal, you have to go for Dick-Salpik. That's diagnostic. When you are suspecting horizontal canal, you go for supine roll test. That is for diagnostic. So if it is a posterior canal, go for therapeutic, either your Siemens or Eplis. If it is a horizontal canal, go for horizontal canal geotropic, go for Buffoni. I have not discussed nearly about 8 varieties of posterior canal, 8 varieties of other canals are there, different position. But I repeat, benign paraxin posterior vertigo, 60 to 70% what I showed, the typical posterior canal amplorian, and the 10 to 20% is horizontal canal geotropic. Yes, Andrija.
Sir, while doing head impulse test or Dick Halpig's test, will even take a small movement as positive for the test, sir. Patient also will move the eyeball. How to differentiate it, sir?
Now you have to ask a patient doing head impulse, you have to ask a patient to look at your bridge of the nose. They should not move. It is a sudden head thrust, a sudden sharp movement, just 15 degree. That's all. If you do more than 15 degree, the eyeball will go to the corner and then they will be correcting seconds even in normal individuals. So it should be just 15 degree and it should be a fast movement. When you make a slow movement, that comes under your second and pursuit. It should be a very fast movement for head impulse. You ask a patient to fix, they have to fix at your eyes. As far as the Dick-Salpik is concerned, whether they fix or don't fix, it is immaterial because you have to observe that. But all the peripheral nystagmus are best when the eyes are, we are not seeing when they are not fixing that. So we can give frontal glass and then record, but I am comfortable with my phone when the phone has the lights on, so they can't fix it. I'm making them blind. So if your phone, if you put the lights on and then record, the recording will be good, number one. Number two, because of the bright light, they can't fix it. You're making them blind. They can record very good amount of nystagmus rather than going for pencil class or in a dark room.
So the next question is, how many days maximum we can give tablet beta-histidine or cinnarizine, sir?
So these are all symptomatic treatment. Like for migraine, we give paracetamol, we give Naxdrome. These are all symptomatic treatment. You can give symptomatic treatment for vestibular neuritis, maximum about 2 to 3 days. If you continue to give for more than that, the central adaptation will not happen. So there will be a prolonged period of vertigo. So maximum 3 days you give for acute vestibular neuritis. And for benign paroxysmal positional vertigo, the treatment is repositioning, not any vestibular sedatives. But they are having severe symptoms. Sometimes they may not allow you to do the test at all. During the time, you can give 1 or 2 days of vestibular sedatives, but
So,
not more than that.
is there any role of ginkgo biloba, sir?
There is no scientific basis of ginkgo biloba in vestibular neuritis or in benign paroxysmal partial vertigo.
So, the last question is, oculogyric crisis can be related to vertigo or canals?
Now, oculogyric crisis is related to your basal ganglionic. So the eyeball, the patient is fully conscious. Now we don't call oculogyric crisis, we call acute dystonic reaction. Most often with dopa depleting drugs like your haloperidol, largactil, sometimes Perina, and your levosulfide. These are the things, especially injectable things, produces acute dystonic reaction. When the acute dystonic reaction involves the eyes, the eye moves upwards, and then they can go for tonic or abnormal posturing. They may go for autonomic dysfunction. This is extrapyramidal syndrome, EPS earlier called, and one form of the EPS is acute dystonic reaction. If acute dystonic reaction is very severe, involves the eye, we call oculogyric crisis. Now, most of the people use the word acute dystonic reaction. It comes under dystonia.
So, that's all, sir. Thank you, sir.
Thank you, Sundil. Wonderful
Thank you, sir.
questions. Wonderful interaction. Thank you very much for giving the opportunity.
Thank you, sir. Good night, sir.
Sir. Yes, tell me.
Couple about 52 years made இன்னைக்கு உங்களை ஓபில பார்த்துருக்காங்க giddiness on and off for 2 days left right side upper limb lower limb weakness சொல்லி பார்த்துருக்காங்க 2 days hypertensive tablets consume பண்ணிருக்காங்க ஜெயராம் டாக்டர் ஜெயராம் சார் பார்த்துருக்காங்க
Okay.
பேஷண்ட் எம்ஆர்ஐ எடுத்திருக்காங்க சார் டிஃபன் காமிச்சிருக்காங்க சார் இம்ப்ரெஷன் ஸ்மால்